So in terms of integrated system working, across the South Coast we've been developing primary care networks or neighbourhoods for just over 4 years now. We have 11 neighbourhoods and they're all at various stages of maturity and development. So it's about how a network may work with a number of different system partners and how one of the outcomes of that work, and I should stress it's not all about money, but one of the outcomes of that work may be that they release funds from another part of the system which they can choose to reinvest a proportion of that funding that is released in improving the health and well-being of their local population. My role is in terms of I'm the Chief Operating Officer, and one of my areas of responsibilities was the South Coast Vanguard, and now I also have a lead role around the development of primary and community care across the South Coast. So essentially we've come up with a framework that enables networks to generate ideas or projects that they want to work on, but that would be dependable or dependent upon funding being reallocated from other areas of our local system. So effectively what they can do is look at how they work with other system partners. Schemes they might want to work on, for example, would be a community liver pathway and how the funding flows across the system to enable them to transform how that pathway may work. So I think the CCG role here is very much to support and enable the networks in developing those ideas and again projects that are locally relevant for them, providing them with a framework that enables them to take those ideas further, look at the evidence and the evaluation in terms of proving the concept, but also then if they do deliver what they've said they deliver, how they can benefit by essentially receiving a share of the funding that is released. And as I said, then reinvesting that in something that's locally important for them. Other ideas and other schemes that neighbourhoods and networks are working on include a care homes project, looking at the care of the housebound patients, and also looking at COPD pathways. So a whole range of different ideas and schemes that they're working on. So our PCNs were, certainly some of them were really the driving force behind this approach. So they were aware that we were doing a lot of work at a South Coast or a system level to look at how we realign some of our financial incentives. And they very much said, what does that mean for us? And again, from a bottom-up perspective, how can we benefit from that type of approach as well? So yeah, they really drove us on this approach. I think one of the real potential benefits of this approach is how it expands beyond primary care networks, also in terms of how some of our other providers work. The neighbourhoods and the networks are really test beds of innovation. What we need to do is look at some of the individual schemes and projects that they've introduced and understand whether they're scalable. So there's a bit for me which is around the scalability of what they're doing. There's also a bit for me which is around saying, how will other networks and neighbourhoods across Lancashire and South Cumbria start learning from this approach and might seek to adopt it locally as well? A central piece of this incentive scheme is allowing neighbourhoods to non-recurrently receive a share of any funding that they save to invest in local priorities. Those local priorities might be about how they particularly improve the well-being of their local populations, whether that's around dementia cafes, whether that's around coordinating singing events for their local population, whether that's around community gardening projects or whatever, but critically that broader well-being agenda. It's a simple approach, it's purposefully not too bureaucratic, and again, really key for this in terms of its success is also CCGs and other partners providing their primary care networks with the support to work up some of these schemes, develop them, and also to evaluate them and then support the spread of them as well. So this incentivisation approach was really based on networks. There is nothing to stop some of our other system providers and partners thinking about how this might work for them internally. So for example, if you're working within an acute hospital, how might this type of incentivisation approach work for your department or your directorate as well? So we really hope that this approach will grow over time beyond networks.